it's good to have you all here for this webinar, which is looking at some of the technological developments in PET-CT. So today we're going to have a presentation from Dr. Ian Armstrong, a colleague up at Manchester University NHS Foundation Trust up the road from us. And it's a great pleasure to have Ian with us, because over the last few years he's done an awful lot of work on PET and the technology therein, which resulted in getting one of the first, what is often sold as the Siemens digital system, although Ian will cringe at me calling it digital, because as we both agree, PET scanners have been digital for probably at least 30 years. But yeah, Ian is certainly an authority on such systems, having the first of that model in the country.
In the world.
In the world, yes. And he was actually, he wasted no time in sending me a picture of its serial number shortly after it was delivered. Anyway, we have about an hour-long slot. Ian's not planning to speak for all of that time, so we should have time for some questions and discussions afterwards. And then tomorrow we've got opportunity for a broader discussion with some other people. And thank you very much, Physics Calendar, or Nick Bird from Cambridge. Without me waffling anymore, I'll hand over to Ian. Off you go. Thank you.
Thank you very much, Peter, and thank you very much to everyone at Christie for the invite. It's very nice to be kicking these series of webinars off. Hopefully something we look forward to participating in the future. So thanks for the introduction for Peter, very nice. As I have, what I'll be looking at here is some of the technological developments in PET. Now, as Peter's just mentioned, tomorrow we've got an in-depth discussion about some of the uses. So I think what the plan will be to try and keep some of the QA a little bit lighter at the end of the talk, because I don't really want to steal the thunder from tomorrow when we're looking in more depth about how best we go into these. So as you can probably guess, most of the things will be on new scanner technology, but there's other few bits and pieces that are thrown in here as well. So let's get going, shall we? So what do we want for a PET-CT system as we go forward? Well, we want high sensitivity. So that means that we'll end up with images which are lower in noise, Poisson noise. That means to be able to see things more clearly in the images. That may therefore allow for quicker scans, better patient throughput, lower radiation dose, both to the patient and also to the operators, because it's worth bearing in mind that if your number of patients go up, then your operators are going to be exposed to more radiation. So that's a workload consideration to think about. Of course, we want something to be high resolution, so we can see the fine detail. And I think most importantly, particularly in the NHS and in these difficult times we're going through, it needs to be affordable. So here's some of the overview, some of the components I'm going to talk about in the talk. So as I've said, and Peter's already hinted at as well, mainly I'm going to look at the PET detector technology. We're going to touch on some of the new, more novel systems which are coming to the market very recently. So looking at some reconstruction, which has some things that have been around with us for a while, but I think it's also, it's worth to recap and also think about how they're implemented on the newer systems. And then finally, one of actually kind of more of a passion of mine is actually looking at motion, because I think it's often a little neglected. And I think, again, that's something which will be coming to the forefront over the next few years. But as Peter has said, yes, I shudder inside when people talk about digital PET, because gamma cameras, PET scanners have been digital for many, many years. So here's what we have as what I consider to be examples of analog imaging systems. And yes, no prizes for guessing who that is on the left-hand side there with the bottle of 12-year-old malt, a sign of things to come clearly. So let's look a little bit about the building blocks and what's brought us to where we are now in PET-CT. So we had the block detector breaking up the scintillation crystal into a series of sub-elements, which gave us an increase in spatial resolution. We then moved on to LSO crystals, which gave a far superior count rate performance of the systems because there was a much lower decay time of the scintillation light. And then finally, we had time of flight, which was actually proposed many, many years ago, but the technology for implementation and clinical implementation wasn't really around till I would say about 12 years ago now, really. So it's only about 12 years we've had commercial PET-CT, time of flight PET-CT. And that's where I'm going to start off looking at, because it's one of the areas of big development in PET-CT. So without time of flight, we have our lines of response. So we've got our detector, the PET detector on the left-hand side, and we've got our line of response in blue. And without time of flight, we don't know anywhere along the line of response where the positron-electron annihilation occurred. So if we look at this now on our image, which is shown by the grid, when we do our reconstruction and we back project our counts, we put them all the way along the image corresponding to the line of response. However, what we have with time of flight is we'll be able to estimate the location of the annihilation event to some degree of precision. We'll talk a little bit more about the precision and how that relates to scanner technology shortly. So what does time of flight do for us? Well, time of flight, again, when the theory of time of flight PET came around, it was demonstrated that it would improve image signal to noise ratio, which is effectively a reduction in image noise. This was dependent on two things, namely the object diameter, d, and the positional uncertainty of the positron annihilation delta x. And you can see this equation here. Now, if we have a Poisson system, we know that the noise is comparable to the square of the, or the square, sorry, the standard deviation is the square root of the counts. So effectively, what we can think about in terms of a signal to noise gain is a gain effectively in scanner sensitivity. Now, these two equations at the top here, these are very much based upon the traditional, the preliminary time of flight theory, and it's very, very crude approximations, essentially being reconstructed with filter back projection measured in the center of a uniform object with a small region of interest, which of course doesn't really relate fully into how our patients are. And we'll see a little bit more later on about how it actually translates into clinical images. One of the subtle differences as well is that, again, these top two equations suggest that our positional uncertainty of the annihilation is a top hat function. In reality, that isn't the case. It's more like a Gaussian function. So we get this factor here that goes to the start of our equation, which reduces slightly the effective sensitivity gain for our time of flight system. So what we can define, and what a lot of the manufacturers are now defining, particularly as we see these more up-to-date time of flight systems with the more modern technology, is we have an effective sensitivity, which is a result of the time of flight gains. So what we do to calculate that is we'll take the intrinsic sensitivity and multiply that up by the sensitivity gain attributed to the time of flight. And of course, as I've said, that is dependent on our object size d and our positional uncertainty delta x. So delta x is positional uncertainty of the annihilation, which is equal to the timing resolution of the system multiplied by the speed of light divided by 2. So the smaller we can get this delta x, the larger the gains in increase in effective sensitivity over and above the intrinsic sensitivity of the detector, the pure sensitivity. That's why what we're quoting a lot now is seeing these timing resolutions quoted in hundreds or several hundreds of picoseconds. And that's what everybody is really interested in as we move forward in terms of scanner technology. But what we'll do is we'll just go back in time a little bit from when we first had our first PET-CTs up at Manchester, or central Manchester, when I was doing my PhD, and we were looking at the impact of time of flight on this was Biograph MCT with photomultiplier tubes. And what we looked at was we resampled the data that we had, and we looked at reducing the counts with various degrees of factors and measuring in the liver signal to noise ratio. So basically what I'm talking about there is put a region of interest, something like that, in the liver, determine the mean voxel values over the standard deviation voxel values and expressing that as signal to noise. And that's a pretty good surrogate for visual image quality. It's been demonstrated and used many times in the literature. So we've got a relatively small patient here, 350 megabecquerels of FDG. And we've got images reconstructed without time of flight on the left, and then with time of flight with a 20% count reduction, and then a 40% count reduction on the right-hand side. And if we look at the numbers, we can see the central image gives us a slight gain in quality, a gain in signal to noise ratio, and then the second image is actually pretty comparable. So we're looking at, for a small patient, if we have a count reduction of approximately 40%, we can get fairly similar image quality without time of flight. As this gets to larger patients, it doesn't quite hold as true. And this is what we found when we were doing our evaluation. So got a larger patient now, slightly increased activity that's been administered. We've measured the signal to noise ratio in the liver again. And now what we see is that we found that we actually couldn't quite get away with the same degree of count reduction. So here we've got the central image with a 16% reduction and the second image with a 30% count reduction. And it's this second image here with 30%, which gives us a fairly comparable image quality. So the theory of time of flight says that the gains should be increasing with larger patients. So we should see the greater benefits with the larger patients. And yeah, when you actually look at clinical images, which are reconstructed with iterative reconstruction, and we have different types of pathology and different uptake, it's not always quite the case. It's not quite as clear cut as it would be according to the theory. And this is a nice demonstration of this. So this again is looking at the Biograph MCT data, photomultiplier system data. And what I've plotted here is the percentage gain in signal to noise over a large number of patients measured in the liver. And we're looking correlation between, or not really any correlation, how this bears resemblance to the comparison with weight on the left-hand side, BMI on the right-hand side. And you can see there isn't really any trend or any correlation in this data. So I think that's one of the interesting points to take home from this, that when you have an iterative process and the different convergent rates with time of flight and different convergent rates with patient size, it's nowhere near as clear cut. So you can't just take the theory and implement changes in practice based upon the theory. So I think it's extremely important that there's an iterative process of optimization which you go through. So what we saw here is we've got about an approximate 22% gain, which is somewhere around there. Hopefully I can persuade you that if I just draw lines through the center of the data points. So a 22% gain in signal to noise ratio corresponds to about an approximate sensitivity gain of about just under 50%. So that's where we were with photomultiplier technology. So how do we improve things? Well, what we're interested in the time of flight is measuring the arrival times of our two 511 kV photons. They're on the two different detectors where the line of response meets the detector. So what we're interested in is that signal that we get off our photodetector. And if we can improve that signal, then we can more precisely localize the start time of when that signal starts being emitted from the photodetector. So we've got Poisson noise through various stages of the detection process. So if we can do something to reduce the noise and the uncertainty on our signal, then we should have greater confidence in measuring when our output from the photodetector actually begins. Let's trace that through for a second. So what we've got here is sort of a schematic diagram of a PET photodetector. We have our 511 kV gamma ray coming into our scintillation crystal. It's absorbed. We get thousands of optical photons produced in the crystal, which can be emitted in quite a lot of directions. They will traverse down the length of the crystal to our photodetector on the photocathode, where we'll get the photoelectrons emitted. And then again, they will make their way down the photodetector till finally we get an electronic signal out of the end of our detector. And we'll get a signal something like, this was very much a hand-drawn sketch, obviously. Something like this on the right-hand side here. And when we're interested in when this 511 kV gamma ray arrives in the crystal, it's this part here at the start of our output of the photodetector that we're interested in. So the more precisely we can detect this and use this signal, then the more precise we're going to get time of flight information. So this brings us on to the development and the introduction of the silicon photomultiplier tube technology. So silicon photomultiplier is actually an array of many, many thousand single photon avalanche diodes. So this is a single detector here, which operates in a Geiger mode. So as soon as an instant photon is incident on it, then it discharges instantly. So it gets an instant signal out of it. There's no buildup of signal like you would perhaps get on a photomultiplier tube. So what we get then is if we put thousands of these detectors onto a module, we can then sum up the signals from each one of these individual SPADs to do things like the energy measurement and the positional measurement on our scintillation crystal, which sits on top of our silicon photomultiplier array and takes the place of our photomultiplier tubes. So what are the gains with silicon photomultipliers? Well, first of all, we'll start at looking at the efficiency. So that's going to dictate the magnitude of the signal which comes off our photodetector. So photomultiplier tubes about 25%. We see a gain of efficiency with silicon PMs of somewhere like 35 to 40%. So if we have a Poisson system, again, we're going to get less noise on the y-axis of that signal that we had previously. Also, we get some timing jitter on both of the detectors, but on photomultipliers, it's larger, so that's going to give uncertainty on the x-axis, the timing axis of our signal. So the silicon PMs have reduced the uncertainty and the noise in both the x and the y axes of our electronic signal that we get out of the detector. So basically, this means that these characteristics mean that we've got a superior ability to measure the time of our arrival of the 511 kV gamma rays, which means we've got superior time of flight performance. One of the things that is important to remember is that we don't have direct conversion to electric signal from gamma ray absorption. We still have a scintillation crystal. And I think that's one of the areas that we may see developing in the future in terms of changes of scintillation crystal. So what difference does it make? Well, here now is a summary table of some of the characteristics of a lot of the scanners which are on the market. I have highlighted the top two in grey, which are based on the photomultiplier tube technology. And what I've got down the middle column here is the intrinsic sensitivity. So this is where our starting point of sensitivity based on the construction and the efficiency of the pure detector itself. Then we can then improve upon this intrinsic detector by our time of flight gains. And our time of flight gains, as I've said, will be dependent on our time resolution. So what we've got here in this column is our temporal resolution, the uncertainty of which we can measure the time difference of our two 511 kV gamma rays. And then just for reference, I've put in some of the performance test references here on the right. So I've put these down in terms of alphabetical order to try and not show any bias or anything like that. So we've got Biograph Vision, these are the Siemens systems, and this is the Canon system, and we've got 3 systems from GE, the recently released 6-ring Discovery MI, and then finally we have the Verios from Philips at the bottom. So what we were interested in is how does these parameters relate to our effective time of flight sensitivity, which we see marketed now by a lot of the manufacturers. Well, this is putting those values into a plot and seeing how it relates to object diameter. Now, again, this is very much based on the traditional theory of time of flight with that linear relationship with object diameter. That's why we've got straight lines everywhere. And you can see that we've got quite a spread in terms of the performance. One of the interesting things here is that a lot of the times you'll say, oh, well, digital is always better. But actually, we've got the 2 systems in the dashed lines at the bottom here based on the photomultiplier systems. And actually, if you have a very sensitive high intrinsic detector sensitivity, then you can actually still have pretty good performance from your system, which can be fairly comparable to some of the Silicone photomultiplier systems, as we can see here. So just moving on to a little bit of our experience. So as Peter hinted at the introduction, so we 10 years ago or 11 years ago now, we had a Biograph MCT, and then we replaced that in 2018 with a Biograph Vision. And we've had a sort of a very gradual optimization and familiarization process with that system, with multiple updates to the scan protocols, reconstruction parameters, etc., etc. So here is kind of where we are at the top, arrived at now. So this is a this is 2 scans from a patient, and this is pre and post treatment for lymphoma. So what we can see here now, I appreciate that we've got fewer lesions on the top sets of images, which is good for the patient, but what we're really interested in is looking at the image quality in these views. And we can see here, we've given the same amount of activity, but the scan time for a vertex to knee is, on the Vision, it's 9 minutes, and on the MCT, it was 16 minutes. The thing to point out here is look at the difference in the voxel dimensions. We're now using 1.6 millimeter isotropic voxels, whereas previously we were using 4 millimeter isotropic voxels. So again, just improving on the image quality. This is always a nice slide to show. I think this is one of the second day of scanning when we had the Vision. One of our consultants came round to the office and said, "Oh, Ian, you've got to see this. This is fantastic." So we've got on the top here a patient measured on our scanner in October. Very large patient, 157 kilograms, but given 280 megabecquerels, so equating to 1.8 megabecs per kilo. And we can see very clearly we've got this uptake in the liver. Now, comparing that back to the scan performed in June, obviously on an older scanner, we can see that the image quality is nowhere near as good. And you could probably say with the eye of faith that yes, it may well still be there, and there may have been some disease progression over these few months, but ultimately we've also got some little focal areas in the liver. And so could you confidently say, oh, this is definitely pathology, or would you think, well, actually you can't quite differentiate that from the general noise texture within the liver? And I think that's one of the fantastic things that we've seen on the scanner, is the real improvement in image quality, particularly in the larger patients. Now, I know most of you in the audience are probably focused on oncology imaging, but again, we do quite a lot of brain scans here, and I think this is a useful slide to show this. We've got a brain scan from the Vision on the top and one from the MCT on the bottom. 15-minute scan on the top, 20 on the bottom. Again, look at the voxel dimension differences. Obviously, small voxels on the MCT, but even smaller on the Vision. The thing worth pointing out is that we don't do any post-filtering on our brain images on the Vision, whereas we actually still put some post-filtering on the MCT images below. Now, actually, and I didn't put a slide in here, both of these protocols were always set up with a bit of insurance in mind, because we were required in list mode, and we only really needed about half of the data, the total data, but we always had a little bit more, just so that if the patient moved, we had the opportunity to still perform a diagnostic reconstruction. So when we come back now to our FDG oncology imaging and just what impact has it had on our scan times? Well, this is where we are up to now on our Vision. So we're looking at the median scan times now, just under 9 minutes, 8 minutes 44 seconds, and there's the range. This is done on a CBM, which is continuous bed motion, so we have the flow motion acquisition, which we didn't have on the MCT previously. Comparing that to the MCT images, you can see that we've pretty much halved our scan times. And importantly, what we do, quite a few vertex to feet, none of those have exceeded a 20-minute acquisition. So this makes it quite nice for scheduling. What I do want to point out is that when we were getting the scanner, everyone was going, oh, how low are you going to go on dose? How quick are you going to go on scans? And I was always sort of like, well, I'm going to be quite, we should be conservative. We actually want to improve image quality. We don't just want to focus on doing things as quickly as possible with as low a dose as possible. Now, we didn't actually, we chose not to change the administered activity because actually we don't have an automated dispenser. We're on hand dispensing here. And our activity in the vial was sometimes very, very concentrated. So we already had a weight-based protocol, which we'll see soon on the next slide. And to try and reduce that and carry on with the manual drawing up, I thought was going to be particularly challenging on the text. So this is this is showing both the protocol in terms of dosing for 3.5 megabits per kilo up to 80 kilograms, and then we chose to keep it at 280 megabecquerels. So this was translated across or brought across from the MCT. I always took the approach that instead of just going up and up and up in terms of administered activity, I thought it was much better to actually stop and cap the maximum activity and then compensate for the degradation in image quality by increasing scan times. And that's what we do still on the Vision. So we've got a range of bed speeds here, as we can see on the key. This is on the flow motion bed speed. And one of the things which is really nice that we see on the Vision that we never saw on the MCT is that this is fairly flat. And this is good because really what we want to do is have consistent image quality across our patient population. Now, when we drew similar charts for the MCT, what we find, I'm just going to change if we were to look at the center, it would always sort of do something a bit like this. And yes, we could have compensated for that lower end of the plot by scanning or increasing the scanning time even further, but it just became impractical, both from a scheduling point of view and also a patient point of view. So we always had a slight fall off in terms of image quality in the very large patients. But now I'm pleased to say with the iteration, and I think, again, what I'm emphasizing here is the importance of optimization, looking at your images, continuously evaluating image quality and seeing where things can be improved to try and reach this final sort of outcome here that we're all going for. So that was Silicone Photomultiplier systems and a little bit of our experience here at Central Manchester. I'm going to move on now a little bit to some of the other systems, the novel larger systems. So when we look worldwide, we can see that the vast majority of PET-CT imaging is whole body oncology imaging, eyes to thighs or eyes to feet, whatever you want to call it. So we're not looking at single organ images. So if we can therefore increase the axial field of view, then this should give us huge gains in terms of our oncology imaging, which is where, like I say, the market really is at for PET-CT. So some of you that may have been following the development of these larger systems may have seen plots like this. And what we're looking at here is a percentage of gamma ray or positron annihilation events, the 511 keV gamma rays, which are incident on the detector. This is purely a geometric efficiency of our detector as a function of the length of the axial field of view. So that's what we're saying on the x-axis of these plots here. And we've got different situations. We've got a point source in air on the left. We've got a point source in water on the center plot. And then we've got a distributed activity on the right-hand plot. And you can see that on the left-hand plot, obviously, it carries on up and up and up to nearly 100%. But of course, when we start introducing attenuation, then there actually becomes a trade-off because the longer or the shallower this angle of the line of response is and the axial direction, the greater the path length is through the patient, and hence the greater levels of attenuation we'll see in that direction. So that's why these curves start to flatten off with increasing axial field of view length. So these are some of the systems that we've seen now being developed on the market and marketed. We have the Explorer system, which is a collaboration from the States and United Imaging. This is probably the most famous of these large field of view scanners, the Explorer, because it was always marketed as the 2-meter PET scanner. We have also a system in Pennsylvania University, which is actually based on a modular design of the Philips Verios system with several of those detectors bolted together to give a 64 centimeter field of view. And then finally, Siemens have just launched their Biograph Quadra, which is effectively 4 Biograph Visions bolted together. Importantly, what I will say is that you'll notice all of these detectors are based upon silicon photomultiplier tubes. So obviously, these things are going to be enormous, and the cheap option would be to go with photomultiplier tubes, but I'm glad that all of these manufacturers went down the silicon photomultipliers, because I think it sort of paves the way for economies of scale for us all going forward in the future. So I think it would be an extremely beneficial, and I think the future of PET is silicon photomultipliers, in my opinion. And so I think as this is a good way of reducing the cost of this and making it a more accessible technology to everybody. So what are the benefits of this? Well, this is some images from the Explorer, and we can see here we've got a series of scan times. I always like to say bed times, but effectively I suppose it is still bed times. It's still one bed position. And we look at how this image quality fares, and we can see here, I always like to pick out this 75-second one, because I feel that this is kind of what we would think about as a good or a typical image quality from our other types of PET scans that we would see, which we'd probably look to say, well, this will probably take about 10 minutes or so to acquire on another system. So this really is a huge step forward in terms of sensitivity and potential applications in oncology going forward. So what does all this mean? These improvements to detectors, both in terms of the time of flight performance, but also the axial field of view. In fact, just everything which is just leading to increased sensitivity. Well, it reduces the requirement to do fix things in the reconstruction. People that know me know I'm a keen photographer, and there's a good mantra in photography that you can fix that in post, or and I always say no, get it right in the camera. And the same is applicable here to PET-CT. The better your starting point of your images, the less you have to do after the fact. So there's less need for post-reconstruction smoothing to control noise. You can design your detector to have smaller crystals, so we can have higher intrinsic resolution of our detectors. We can reconstruct into smaller voxels, gives us better sampling. So all of this will lead to better image quality and increased visualization of our smaller lesions. So that's the hardware, that's the technology. Now we're going to move on to that sort of post-processing, the reconstruction. So PET for many years has been iterative reconstruction, and I'm not going to give a lecture on that, but hopefully those of you in the audience will appreciate that what we do in iterative reconstruction is we make an estimate of what is actually in the patient. So we have an image, which is the estimate, and then we do more and more iterations, and we say that we can converge to the most likely estimate of the image representing what is in our patient. And we can carry on going, but our estimate doesn't really get more accurate. What it does do is get noisier. And so this is a nice example of this. We can see that as we go increasing numbers of iterations, our images may, if we draw large regions, so a large region in the liver, for example, the mean may get more accurate, the SUV mean, but you can see here we've got substantial image noise, which basically makes this image non-interpretable. So lots of things that we can do to try and control that. So here's some of the reconstruction algorithms for Siemens and GE. So we've got resolution modeling. Sometimes we call it PSF modeling, sometimes we call it resolution recovery. Really depends who you talk about. I'll probably interchange terminology throughout the talk as well. And we've got the names of what the manufacturers call it: HD PET, Sharp IR. That's a reconstruction process. We've got time of flight, which I've spent a lot of time talking about. That is not just reconstruction, of course, that's also hardware dependent. And then finally, we've got the regularization, the penalization, which is again is a reconstruction option, which is aimed at controlling the propagation of image noise through the iterative process. And GE marketed this as Q.Clear. So all of these options here improve image quality and noise reduction. So we're basically having an increase in signal to noise ratio. So what we have here, we've got an image with Q.Clear on the top and time of flight on the bottom. And again, what I've done is I've put a region in the liver, and you can see we've measured the signal to noise ratio, and we've got a signal to noise gain with time of flight alone. So that's down to the suppression of image noise in the iterative process. Now, those of you that will use Q.Clear will know that it is actually, you can't apply post filtering or iterations or anything like that. That's all set in the system. What you do define is the beta value. The beta value is the weighting to the penalization that is applied to the noise propagation. So the higher the beta, the greater level of penalization applied, and the less noise is allowed to propagate through the iterative process. The lower the beta, the more noise, and effectively the more fine detail as well. And it's based on count density. So one of the things I wanted to focus on is, well, what is appropriate for these, as these systems get more and more sensitive, both from a construction point of view as they get larger, but also from a time of flight point of view, how do we use these, something like Q.Clear? How do we control the noise propagation through it? And this is a nice example here of a recent paper where they looked at the comparison of the Discovery MI, which is the silicon photomultiplier system, and the Digital Ready, which is the PMT system. And what's quite interesting here is that with a beta value of 350, you don't really need to put any numbers in on this, but you can quite clearly see that there's actually been quite a lot of suppression in the detail. And I presume that this is due to the fact that the images had such better count statistic that maybe there was an overcorrection of an oversuppression of the noise. So, you know, this isn't my work, but I think that, again, this really does point out the importance of optimizing your reconstruction based upon the technology that you've got. So that was looking at noise. Of course, what we're also interested in from a reporting perspective is our SUVs, and almost ubiquitously SUV max. So again, those of you that are using technologies will know that they result in a change. We've got an increasing signal to noise ratio. So typically what we see, that signal being our SUV. So that's what we tend to see increase quite a lot. So we will have plots like we see here. And again, I'm sure a lot of you are familiar with this. With the smaller lesions, we get this trend, something like this, where we have greater change in SUV max, inversely related to our lesion size. So that's quite an important thing to think about. Now, one of the things that we are interested in is that, yes, things will change. Does it ever get any more accurate? Well, we don't really know. One of the things that we can do, of course, is use our old friend, the NEMA phantom, where we can put spheres with known activity concentration in and measure what we see for various processes and look at accuracy and bias or whatever in those 6 spheres and define our recovery curves. This is I say a nice tool. It's kind of the only tool that we have for harmonization of quantification. But it's very important to remember that it's done under very prescribed conditions. And this is a fixed geometry phantom. The counts are very sort of standardized. The activity that we put in is very standardized. So it not necessarily will always translate to clinically harmonized, and we'll see something about that later. So this is just setting the scene here. So I'll take some of the points that I raised about the, I've sort of applied our reconstruction and our comparison of the NEMA phantom data to some of our reconstruction options that I talked about previously. So one of the things I want to talk about first, of course, is resolution modeling. That was top of the list. It gets quite a bit of bad press, and it has done over the years, things like the Gibbs artifacts. Gibbs artifacts are the edge enhancement. We can see we've got this highlighted here on these spheres. So we've got the sort of the traditional photomultiplier technology in black and white here, and then we move to full color here, silicon photomultiplier systems. And we can see, quite interestingly, that we still have some evidence of Gibbs artifacts, these donut-shaped spheres, but they are nowhere near as pronounced on the more modern scanner compared with the photomultiplier system. That's because as the scanner technology and the scanner design gets better and it gets more inherently superior in terms of spatial resolution, the resolution modeling, PSF modeling, it's got less to do in the reconstruction. So like I say, get it right in camera, get it right first, and you don't have to correct as much in reconstruction. And really, a lot of the people attribute these Gibbs artifacts to effectively an overcorrection or trying to overcompensate for losses in spatial resolution in the detector and never really being able to get it back properly. So what does this lead to? Well, it leads to NEMA recovery curves like this. So anybody that's done any work with PET and trying to harmonize, we will know that when we have PSF or resolution modeling, we get curves like this. So this is data from the MCT. And we can see we get this hump, this non-monotonic response with size, which can cause quite a lot of problems. We've got the two curves below without PSF, just with time of flight and without time of flight. Just for completeness, just in case anybody's curious, the two black lines are the Earl harmonization limits as well. So again, you can see why this was a problem with the traditional Earl 1 harmonization. If we then go, however, across to the data that we measured here when we had the vision, you can see that because the resolution modeling is doing less, there is less of this overshoot. There is barely any overshoot, really. It's actually the UHD on the top, which has got the resolution modeling incorporated into it. So we don't really have this big bias, and we still have a relatively monotonic response, which is what we're interested in, really. So this is now, that was Siemens data. What we've also got now is some GE data. So this again was on a silicon, not silicon, but this is on a PMT scanner. Some data from Lucy Pike, and you can see here on the SUV Max again we've got this bump on the on these specific sphere sizes. Now I don't have any data for the silicon photomultiplier systems like this. I was trawling the literature. Problem is everybody does the NEMA measurement or the NEMA acceptance measurement of the recovery curve, which is basically a two-dimensional region of interest, and you measure the entire mean, which gives you a plot like this on the left-hand side, which always almost certainly has negative bias. Nobody really publishes much data or has found any data with SUV Max as the right-hand side here. Now, if anybody out there is listening has got some Max data with Q.Clear on a Silicon PM system, I'd be very interested to see how it performs compared with the older PMT systems with Q.Clear. So yeah, feel free to get in touch. So let's look at where we are now in terms of what we are doing. So this is our sort of where we finished up on the MCT in red and where we are now on the vision. And again, this, like I said, this blue curve on the vision, this is actually our fourth iteration, which, you'll have to pardon the pun, but that was our fourth iteration of our scan protocol. And I mean the scan speed, the reconstruction parameters, all of that, we went through a process over about a year of optimization and continual updates. So as you can see, there are differences in the recovery, which will translate to differences in SUV Max. Now, when we started, I said to the clinicians, I said, look, SUVs are going to change. They're going to go up. And of course, what we did was we had the side-by-side imaging of trying to match the parameters so they could get a feel for how things had changed. So it is possible to match by changing your parameters accordingly. So again, we've got some data here on the left-hand side from the GE system with Q.Clear. This is from one of the papers from Oxford. And you can see with an appropriate beta value, you can match to a non-Q.Clear reconstruction. Similar story with, this is MCT data here on the right-hand side, which is also and compared with PSF time of flight data. So you can match in the NEMA Phantom. Like I said, though, that is only in the NEMA Phantom, and it's important to remember that because this this data here was from one of the papers I published a few years ago, where we looked at the impact of matching quantification of the various reconstructions and how that then translated clinically. And you can see here, it isn't perfect. So this is with apparent using parameters for both time of flight, PSF, resolution modeling, and then the combination of the two. So these parameters were defined upon NEMA data, which should have given the same SUV Max recovery. And you can see here with our, when we put time of flight on, there is clearly a subtle trend, an upward trend in our smaller lesions. And that could all be coming down to differences in iterative conversion rates with patient size, with lesion size, things like that. So it's important, very important to, again, look at what's happening in your patients. It's not just about phantoms and theory. The most important thing is look at your clinical data and see what the impact is to understand it. And I think one of the more, again, very important things to understand, we talk a lot about things like Deauville and persist, but this again is another example of Deauville. And we say, well, if we harmonize our SUV, then things like Deauville will always match. But of course, Deauville relies on a hepatic reference region. So what we see here is two images produced with harmonized parameters where they harmonize the lesion SUV max. Now, because we've got much better noise suppression with our UHD reconstruction, if we harmonize the signal, we hugely suppress the noise. And that's what we see here in the liver. So if we look at an SUV mean in this region, we can see that it's very comparable across these two reconstructions. However, let's look at the SUV max, which is really dependent on our noise in our liver. And we can see there is a huge reduction in SUV max in our harmonized image. Now, this is important because clinicians out there, if they are putting things that are relative to hepatic SUV max, and you're saying, is a lesion greater than SUV max in the liver, it may change. It may change because if you've got a lesion with, say, 2.6 SUV max, then of course on the OSEM it would have been lower than liver, whereas on the UHD it would have been higher than liver. So that might have changed your viewpoint. And again, I think that just highlights the importance of appreciating the full impact of these reconstructions. So that's reconstruction and all the gains that come with that. Finally, as we start to wrap things up, we've seen that we can have lots and lots of improvements to our images. We can increase our image quality, we can reduce the noise, we can improve the signal. Of course, the patient still moves. Now, we can scan faster if we have patients that are in pain. For example, there is certainly some benefits to having a system which allows us to scan faster and mean that we might minimize some degree of motion due to discomfort. But of course, they still breathe, okay, obviously. And so that for lung lesions is always going to be a potential issue. Now, sometimes we've talked a little bit, I've heard mentioned a little bit about people trying to do breath hold PET, obviously a little bit like how we would do in CT. Now, even on the silicon photomultiplier systems, I personally feel it's challenging, and don't think we're quite there yet on these standard field of views, because I don't really think we have the sensitivity to get something which is useful out of it. I'm sure, though, on the huge sensitivity that we have on these larger axial field of view systems, it probably is possible. So maybe we could do a 15-second breath hold PET. Then, of course, what we need to think about is matching our position of the PET exactly to our CT. So again, that's another challenge to think about. So why is it important? Well, again, I'm sure I'm not teaching you anything new here, but I think it's always good to repeat things for anyone that's not seen anything like this. We've got these lesions here on the border of the liver and the lung. Now, where are they? Well, we don't really know. They could be in the liver and they could be in the lung, and it all depends on the different phases and the different positions of the CT and the motion blurring of our PET. So if we just do things like motion correction, we would localize those lesions correctly. What we also have is the fact that when something is moving around, things are getting blurred. So again, our SUVs are going to be reduced. Now, what the traditional motion correction techniques do is they separate the data. They do essentially a series of gated images, and they separate those out into, say, 4 or 6 different images, which of course therefore have lower count statistics than just a summed static image. So our individual gated images may be more correct in terms of position, but they'll be far more influenced by image noise because of the reduction in count statistics. But what the manufacturers are now doing is having this technology where we're producing these motion-free images, and they're actually preserving all of the count, loss, all of essentially retaining 100% count in our gated images by using some sophisticated optical flow technology. So we can see quite clearly here we've got pretty comparable quality in terms of the noise, particularly if we look in the liver here. The noise looks pretty comparable, but we can see that we've really reduced the impact of our motion, and this lesion here in the lung is looking much more clearly defined. So I think that's an important thing to go forward with. Now, current generation motion relies heavily on motion management or measurement. It relies heavily on the external system, so the belt or the camera. This, of course, is increased setup time, both for the patient and the technologists. Those of you that use them, and I include ourselves in that, will know that they're not 100% robust. They can quite a few technical issues with them. We, of course, assume that the external motion correlates to what's going on inside the patient, but we can have challenges if we don't really detect that external motion very clearly. If we wrap the patient up in a lot of blankets, for example, and if we're using the camera system, we may not be able to really detect what's going on internally. So it's not an ideal solution. And I would say for things to be adopted into routine practice, they need to work, they need to be accurate, they need to work consistently, so it needs to be reliable, it needs to be easy. We don't need complicated setup, we don't need operator dependence, we don't need things to go wrong or not really relate to what's happening in the patient. Of course, it needs to be affordable, or at least relatively. So I really do think that the future of, and I suppose actually the present, because it is starting to be rolled out now, is data-driven motion correction in PET. So if you can basically get it for free from your standard PET acquisition, I think it really will become a routine practice. And I think it's something else that we need to start paying attention to. So I'm going to start summarizing now. So we've seen that all these advanced PET reconstructions and our scanner design, they really do increase the signal to noise ratio. So we've seen that we can get our increased lesion uptake in our small lesions, SUV max. So it's really important to understand what the images are being used for reporting. There's no, when you look at the literature, there's no, and when you look at the NEMA recovery curves, there's no real evidence that reconstruction is any more accurate. These advanced reconstructions have provide any more accurate quantification. Yes, when we look at SUV mean in the entire sphere, that will be increased, but we don't use that clinically. We use SUV max. And so what that tends to be is we may have an increased positive bias in our SUV max in certain sphere sizes. So I would never say, I always say we're never really accurate. Okay, the best thing we can ever be is consistent. Because as we've seen, the impact of the reconstructions is really strongly dependent on how they're configured, what the iterations are, the parameters, the beta, the filtering, etc., etc. And you can set that up in any way possible. And I think it's really important to, whatever you do, you measure it on your population and you see how your image quality is across your population. I think that optimization is really, really important. For those clinicians, when we're looking at SUV max and we're using it for guiding us for differentiating between benign disease, malignant disease, again, when you look at the literature, it doesn't really suggest that the algorithms offer any advantage in differentiation. All it does is the number changes, but it doesn't really provide, from what I've seen in the literature, any real benefit. It's visualization is where, that's the key. It's seeing things that you didn't see before. But what you really need to be careful with is follow-up scans, particularly if you're going from an old scanner to a new scanner or you change reconstruction. And again, these reconstructions need to be assessed against the published guidance, things like Deauville and Persist, and look at the impacts of that. Sometimes it may be necessary to do 2 reconstructions, but trying to be a little more, positive on things. Of course, now we've seen silicon photomultipliers. It's a huge step change in PET performance. We've got massive changes in time of flight and effective sensitivity gains. And I think we'll see in the future, again, things becoming larger and motion management becoming increasingly relevant. Now, what do I want to see in the future? Well, I think, like I say, the economy of scale, which is probably going to be driven by mass production of these systems, larger systems, will make this more affordable. I'd like to see things like a 40-50 centimeter axial field of view, because I think it's a nice sweet spot for most departments. I'm sure we're still going to see improvements to time of flight. I think maybe over the next 10 years, we'll probably get down to about 100 picoseconds. But I think in terms of the fundamental performance of LSO, I think we've almost reached its limits at about 200 in a big detector ring. I think there needs to be some progress in the scintillation technology. So that'll be interesting to see. I can say, I think we'll start to see the adoption routinely of data-driven motion correction. Something that I haven't touched on, because I basically know nothing about it, but it's of course is the buzz word of the moment, is machine learning, artificial intelligence. I think there's going to be a lot of adoption of machine learning in terms of denoising and noise reduction and image reconstruction and enhanced noise, and enhanced detail again. So that'll be something to keep an eye on, certainly. But concluding, now, those of us that, and I don't really count myself in this group, there'll be plenty of people out there that have done PET for many, many, many years and have seen all of the technological advances in the field. We've got from PET to PET-CT, 2D acquisition to 3D acquisition, filter back projection to iterative, and now most recently, photomultipliers to silicon photomultipliers. I think the thing I want to get across is we shouldn't be scared of this. We should embrace these developments, because it's a win-win for everybody, really. We can get better images, better diagnosis. We can scan quicker. We can reduce our dose to the patient. But there needs to be work to do. It's not quick. It's not easy. Like I said, we probably did about 18 months of a rolling process of optimizing the images on the vision, reflecting, observing and evaluating the changes that we did, and then maybe moving forward again if needs be. And I think the key thing here is that you've got to work together as a multidisciplinary team, the physicists, technologists, clinicians, everybody together, because this needs inputs from all of the specialties to really make the most of this technology. And I'm sure, again, we are continuing to advance, and so I think adopting this sort of philosophy and this approach is just a very positive thing for the future. So thank you for listening. I have no idea how long I actually talked for there. I will stop sharing my slides, and then if Peter has got any questions.
Excellent. Thank you very much, Ian.
Thank you very much.
That was really good.
Good.
Splendid. And I think that really brings home that technological advances aren't just a different photo detector at the back of your scintillator. There's a lot more to it than that. We have hit 2 o'clock, but
we have, yes.
I'm not going anywhere for a while yet anyway. So we've probably got time for a few questions if anyone wants to put them either in the Q&A section of Zoom or just in the chat, or whatever suits you, really. Whilst people are thinking of things, we have got actually while people are thinking of things, and I think there's one come through already. I'm going to ask you a question. So particularly, one of the things you mentioned was the increased optical photon efficiency of silicon photomultipliers.
Yeah.
And I can't remember the figures for our old system and your new system in terms of scatter fraction. Should we be using that efficiency to try and get scatter fraction and really attack scatter, because that's the enemy a lot of the time?
Yes, I guess we could. How would we use it for scatter? Yeah, I mean, I appreciate scatter is. How would that attack scatter as such?
you're getting more photons, so
Yeah.
potentially you can have your energy resolution will be slightly better.
Oh,
So
yes.
you can have slightly narrower windows. Years ago, one of the main
I
differences
guess it will
from
be. Yes, I get. Yeah. Okay, I can see. I do wonder whether it would really make a lot of difference, because the energy window is huge on a PET when you look at it. I can't remember I don't know what the windows would be off the top of my head. I think it probably. I think what it may make more accessible is updates to the scatter correction algorithms. I know that when we look at the sort of more traditional scaling by the tails and things like that, that we may utilize the data, and particularly the time of flight data, more to look at absolute scatter, which I think is something that is on both of our systems. Yeah, I don't know how much difference it would really make. I suppose I'd have to sit down. I think it was only about it was 25% on the PMTs and about 35% on the silicon photomultipliers. So I'm not sure that you're going to get a hugely increased
Okay, thank you.
efficiency. Yeah,
It's almost a question as much for manufacturers, because when I
yes.
say we don't actually design systems. Just to move on to another question, David was asking, thank you very much for an excellent and interesting talk. Regarding motion, I know that using Xbox technology was looked at once.
It was. We did some here with the, I can't remember what it's called. What's the camera called?
Connect.
Connect, thank you very much.
Yep.
Yes, we did. Yes, but again, it's the same caveats apply. You are looking at something which is external and translating that to internal motion, and it's an additional setup. Now, there's been a lot of things looking at it. I think it would work very well in head tracking, but the body, I know we looked at it very briefly as an application for motion correction, respiratory motion correction. But then the things what you've got to think about is usually you've got to have some complicated mirror arrangement in the gantry where we're looking down at the patient's body and trying to get basically an up-down motion, where effectively, of course, respiratory is axial. So we did look at it briefly. I'm not sure. I think it's one of these sort of, yes, it would be nice to, but as the data-driven technology progresses and becomes essentially more available, I think that's just going to supersede everything, personally.
Yeah. Actually, in the Q&A bit, I think I know my answer to this, but I'll let you answer it. Do you think PET MR will replace PET CT?
No.
Thank you.
No, I think. Well, there are reasons. I think from the experience here with the MR, I think that everyone thinks that it has its application, certainly, but I don't believe PET MR will ever be an eyes to thighs oncology imaging. I just don't think that's going to be the case, because it comes down to time and MR sequences for limited field of view. For example, single field of view bed, or maybe we're looking at novel traces or prostate or something like that, then yes, it has an application, but it will never replace PET CT.
Okay.
In my opinion.
Matt was asking, great stuff, Ian. Can I ask where you said 280 megabecs was capped, and then you're adjusting the speed of scanning, which is what you do on your vision.
Yeah.
Although I think the early patient you showed going up to 450.
So thanks, Matt. So that was
400.
basically a very old image. That was when we first had the MCT. So that's probably about an 11-year-old image. So where we started at, we did it. We didn't even do weight based. We did 350, and then we did 400 at I think 100 kilos. So that's where that came from. But yes, again, it just highlighting progress really. But the 280, the sort of 3.5 megabecs capped up to 280 is something we introduced on the MCT. And as I said in the talk, we just carried that straight across to the vision, because I think drawing up those tiny volumes just is not practicable in by hand. If we had an injector, maybe, but I think, Peter shares this approach. I think, it's the balance. I wanted to get better image quality. I didn't want to just match what we were doing on the MCT. I wanted to move forward.
Yeah. I think we have a slightly different approach. We go all the way up to, well, with older technology, we go all the way up to 400, just because I think you've got to have a line in the sand somewhere. What am I looking at? Heather was agreeing with you about, I think, broadly about the kinetic for, just gives you a surface map. Ahmed was also asking how we apply multiple correction techniques at the same time for one patient. So yeah, talking about things like if you're doing a cardiac scan, you've got. I'm
trying to work out what all of those corrections. I don't know what a stent correction would be and a truncation correction would be. I'm trying to think that through, what that's actually getting at. Well, there's a variety of things, of course. We've got ECG gating, which corrects for the contractile movement of the heart. Anybody that's interested in any other types of motion of the heart, I would definitely direct to some articles I've got in JNC, Journal of Nuclear Cardiology. So we are at the moment developing some data-driven dedicated cardiac motion correction, and we've got an open access paper in there. So if you just Google me and Journal of Nuclear Cardiology and things like that, you'll find it. Truncation, well, the truncation is taken care of because the CT has got an extended transaxial field of view of, let me get this right, I think it's 780 millimeters. So that would pretty much take care of that. So yeah, most of those. I think maybe stent was metal work, perhaps, thinking about it now. So we have metal artifact correction on the scanners as well.
Okay, thank you. We'll just go for one or two more. Jan was asking about development of silicon photomultiplier tubes driven by development of PET MR. It seems to be that's the way it's developed. I don't know if you know the history of them.
Well, let's not forget, it started with the APDs. We forget the unloved APD, but it started there on the MMR, which of course was a very slow detector, which wasn't capable of time of flight, and then was superseded by silicon photomultipliers. But yes, it's always sort of touted as the sort of PET-MR gave birth to the silicon PMs. But I think we probably would have reached this, we would have got there anyway. If anything, I think what happens is PET-MR probably just accelerated it slightly. It gave the stimulus to do it. But I think photomultipliers were living on borrowed time, really, for a while anyway.
And a couple more comments. So Matt says we too go for 400, and thus far have kept this on the new Vision at Clatterbridge, Liverpool. Yeah, so they're sort of still learning and ramping up with the new hospital.
Get in touch.
Nick, and also known as Physics Calendar, with data-driven motion correction, presumably without, I think he's asking about the Cine CT. So I think it does sort of highlight the complexity of the problem. You've got a moving PET and a moving CT and done at a different time.
Yeah, absolutely. I and one of the things I'd like to see it go full circle is that we would actually go back to doing attenuation correction from the PET and almost go back to, I wouldn't say the transmission days, but now with the improvement of time of flights, we look at things like, what do we call it, the joint reconstructions, MLAA, MLACF, where we're actually deriving attenuation correction factors based upon the time of flight data and not the CT, which of course gives you inherent registration. There is no misregistration issue. So I think that's, I don't know, it seems to be one of these things where it's a nice idea but not quite taking off. So who knows? And again, maybe, you know, my default answer at the moment is actually becoming, oh, that's a problem for machine learning to sort out. So, so who knows? Actually, maybe you just throw the PET data into a neural network, and you get an attenuation correction reconstructed without any CT or anything. Who knows? Who knows?
Simultaneous CT?
Maybe. But I don't know what I said then.
Right. Okay. We are coming up to an hour and a quarter now, so I think we might have lost one or two people. But it's probably a good point to wind it up. I'm sure Ian and I could talk PET scanner technology long into the afternoon, but we better spare you from that. So thank you very much again, Ian.
No, thank you.
An excellent
thank you,
talk.
like I say.
And we'll be back here at the same time tomorrow for more of a sort of a broader discussion about how new technology can be used with Ian again, and also people from SIDCUP, where there's the GE Silicone Photomultiplier system, and getting into more of the sort of practical detail about how systems are used. We've also got Prakash Manoharan, our local nuclear medicine lead. Right, okay. So thank you very much, everyone, for attending and your questions and input. And thanks very much again, Ian.
No problem at all.
And see you all again tomorrow.
See you tomorrow.
Cheers.
Yes, thank you. Bye. Take care.